the whole purpose of coming together to work is to improve the standards, the experience of care for patients and families. And nothing short of excellent should be good enough. My role here in the United Kingdom has for a long time been as an Associate Director for Patient Safety in an academic health science network, research through the School of Management at Bath, and an ISQUA person-centered care expert and board member. And my clinical background is as a diagnostic radiologist. So I bring all those experiences to bear on trying to share with you today my experience and what I've learned about what makes a successful collaborative. And the collaboratives that I've been involved with have been large, in UK terms anyway, the one on the right, which we started in 2008 with the Institute for Healthcare Improvement as a very substantial partner. And we started in the part of England that I live in, the Southwest, and we focused on safety in hospitals, in community environments, and then a couple of years later, we added in mental health. And that collaborative then spread across the whole of the south of England for mental health improvement. It was extremely well received. We were very successful, and we ran the collaborative for 5 years and made a significant impact on standardized mortality across all the institutions that were partners within it, really improving the outcomes for patients across the system in the south and southwest of England. And then more recently, in the last 4 years, but it will run through till 2022, I've been developing a different type of collaborative focused very specifically on children and young people with diabetes, all of whom have outpatient care given by specialist teams throughout England and Wales. And there are 172 teams across the hospital system that look after children and young people with diabetes. And we've designed and developed a collaborative there in waves. So rather than one big group, we're running groups of 10 or 12 hospitals through in waves, starting them every few months, so that we have different maturities of experience running at any one time. And that's a different design. And it's also a very different design now, because you can imagine over the last year, we've gone from meeting together to actually doing this virtually and online. And so what I want to share with you is why it is so important that the design and the leadership of a collaborative is aligned, why clinical involvement needs to be energized and that energy sustained, why the aims of the collaborative need to be very clear, and why you need to measure, measure, measure at all steps in order to demonstrate that you are being successful or that things are slowing down and new ideas need to be brought into the environment. That everybody participates, all ideas may be useful and may be tested, and that celebrating success is a key ingredient, just as much as learning to manage to test and fail fast so that we learn quickly what works and what does not. So if we look at the word collaboration in its derivation, it means to work together. It's not just about coordinating or cooperating. It's actually about coming together to do the work. And it's very much, as this photograph shows, about frontline staff sitting together, looking at evidence and best practice, and discussing with each other what it is they need to change in their own daily work in order to get closer to what best practice should be. Measuring is vital because as we work together, what we discover is some things aren't working as well as we would hope, and that change is often up and down, certainly in the early part of a collaboration, where often when you're starting out, you're exploring and understanding more about what's going on rather than just putting into practice what you know should happen. And as you can see on this run chart, time-ordered data from the collaborative that we ran in the southwest of England, we developed a bundle of things that needed to happen to put a central line in safely to reduce the risk of infection. And we then educated staff, coached staff, developed ways and means that this would happen in every clinical environment where a central line was important. And you can see it took a couple of years for us to reliably do the work in this way. So sometimes I think we underestimate how long change takes to become substantive and reliable and resilient under all situations. So I like to think of a collaborative as an engine driving improvement. And as you can see here on the right, 3 key areas of energy and work. Firstly, that professional cultures promote working together and sharing and better teamwork. That secondly, there is an encouraging and enabling environment, whether it's a community of practice as the one you're in, or whether it's the facilities and the support you get from your own immediate organization and leadership. And that we learn, share, and celebrate at every step of the way. And that lastly, whether we are clinical leaders, organizational leaders, patients, families, managers, clinicians, or people supporting IT or facilities, or catering and housekeeping in an institution, that we all work together, because when we all put our minds together, that's when improvement can very rapidly happen, and it's when improvement will stay with us even in difficult times, such as the ones that we're in at the moment. So there's a couple of references on this slide, and I will make sure the slides are available to everybody, which might just help you understand a little bit more detail. So in principle, the design of the collaborative process is really important. It's a journey, and whatever vehicle you're in, you're moving forward, and you're moving forward with other people. So preparation at the beginning is key, and preparing yourselves and your team and your system for participation is important. But then you come together to share what you know, to learn new approaches, to collaborate and explore with each other ideas, and then to go back to your base to do the work, to put some of these ideas and this learning into practice. You then come back again to share the progress you've made, maybe at a 2 or 3 month interval, to perhaps learn new quality improvement tools that would seem appropriate to the work you're doing, to discuss challenges you may be having, barriers or measurement challenges, and to work together again and to share with others so that you can learn from each other, and then go back to your work environment to carry on refining and improving the care that you're giving for patients. So as I've already mentioned, our Southwest Collaborative went on for 5 years, and we initially met every 2 or 3 months. And then we, at year 3, moved that to 6 monthly meetings with interval phone calls and connections. Our Pediatric Collaborative is, we get together every 2 months, and we run it for 9. And then a new wave starts, and we bring the previous wave's expertise into the next new wave as experts by experience in using the tools and improvement methods that we share. Now, what is really important in a collaborative is the way we talk with and to each other. It's about the importance of dialogue rather than discussion. Discussion is often how we communicate with each other as clinicians and clinical teams. We focus on the difference between your service and my service, the difference between what's expected of us and what we're doing. We tend to come up with quick ideas and lock in solutions very quickly. But dialogue is much more fruitful and a much more successful approach in a collaborative environment. We listen to what others are doing. We speak with people and ask questions and gain insights about what they're doing and what our experience of doing the same might be. We reflect and our ideas emerge rather than we bring them to the table and they're immovable. And so we might say, well, actually, now we've thought about it, we're going to test this modification of our idea out rather than what we thought of immediately. And this ability to reflect and develop emergent thinking is very powerful, because if we knew the answers to the problems that collaboratives are dealing with, then we would almost certainly have fixed the problems already. The fact of the matter is change has to be an emergent function, especially in clinical practice, where we don't want to add risks to what is already a rather risky situation. So I like to think about it in terms of these two pictures of the Ganges at Rishikesh, in that we might be relaxed on our hammock under the bougainvillea and thinking about what we're hearing from others, at the same time wanting to fly and take off from the water's current in order to make change. And when we're collaborating, we need to have leaders who can lead their own organizational team, but also lead with other leaders from other services, so that we work as peers, collaborating, coordinating, co-designing and evolving services that best suit our environment. And it's that peer engagement and peer involvement that is very powerful in bringing people who are perhaps resistant to change or reluctant to see the benefit of change and to bring them with us. Whereas when we're working on our own, sometimes that can be a very challenging thing to achieve. So the research is interesting about collaboratives. And I've put a table up here from a research paper, which the link is here on the slide. And they talk about leadership, design goals, quality improvement skills, and teams as a very rich mix that needs to really work together. That we need quality and systems improvement as a core strategy, that we need clinical leadership that's supported by professional management, not in conflict with them, that our organizing design is about a high functioning team working with other high functioning teams to share and learn and adapt. And that improvement capability is built through the experience of the tools we share and then the putting of them into practice as part of the work we do when we return to our workplace to make the tests of change that we have developed and shared at the collaborative meeting. And I think this is quite a powerful table just to reflect on, because these criteria and these characteristics are really vital for a collaborative to be successful, because we need to transcend these traditional hierarchies of research, expertise, and implementation. And we need to allow change to evolve and adapt swiftly, but also specifically to the environments that we're working in, because no two environments will be the same. So I want to use the 5 Ps of the microsystems methodology now, just to flag up some of the vital parts of a successful collaborative. The first is purpose. Having a clear aim for the collaborative that is translatable into local improvement by local teams. What are we trying to achieve? How much improvement do we want and by when? Why does this matter to patients? And why do we care so much about it as professionals? What will we see as benefits if the changes that we make are successful? And can we think of any barriers ahead that may get in the way so that we can work with a wider stakeholder group in order to overcome them? Sometimes the barriers may be our connections with other parts of the system, whether they are social or education or different professional groups. And sometimes the barriers will be very practical around equipment, IT, perhaps facilities. So ensuring a wider group are working together is really, really important, but the purpose must be the same. Secondly, our patients. We need to understand more about them than we do now. And to start with, it's worth spending quite a bit of time on starting to understand the patients that you're talking about and that are the focus of your collaboration, and understand more about them as relevant to your practice. How many patients in this particular group that you are working to improve the outcomes for do you have? What are their characteristics? What special situations in your experience will impact on the quality of the outcome for them? What do we already know about what works and what is not working well enough? And most important of all, who's the best in class? How do we find about their approach, and how do we learn from them and with them so that we learn, listen, adapt, and learn more? Secondly, the professionals that we are collaborating with, our own team. Now, a high-performing team of professionals is the real engine for improvement. And a high-performing team may need to develop high-performing habits if it doesn't have them already. So we spend quite a bit of time coaching teams to be disciplined, to learn how to actively participate by everyone present, to have someone looking out for people who perhaps are less confident to speak up, who almost always have great ideas that need to be added to the conversation. That a great team meeting has an agenda and a purpose, and it sticks to it. It sticks to the time it's set aside respectfully, because people haven't got time to waste. And we often say 10 minutes, 15 minutes, half an hour is a great start until you start to realize the benefit of a highly disciplined meeting and realize that you can make it work for an hour, and it saves at least that time in the rest of the week through your more efficient and productive working patterns. And high-performing team meetings attract people to them because they trust the value of the meeting and they see the benefit, not just to the patients and to the service, but to each other as professionals. Patterns and processes, the other 2 Ps of our 5 Ps. Patterns of how presentations happen, how care is given, the circumstances in which it works well and the circumstances in which it does not. These are vital insights to spend time on, because as Deming clearly articulated in his lens of profound knowledge, understanding the system where the work is delivered, the variation in how that system performs, the theories of why things should work and whether they do, as well as the psychologies of human behavior when confronted with change, all need to overlap and work well together for quality improvement to be at the center of what is happening. So we often encourage people to use the lens of profound knowledge as a video link to give you an idea as to how you might do that, just to stop people jumping to conclusions about what the answers are immediately, and to take a step back from the action that we are all desperate to get on with, and just think a little bit harder about why things are as they are currently, so that we ground our improvement work in the reality of now, rather than leap straight to solutions. So a few other key things that I know you will have thought of, but I also know how important it is for every single member of the collaborative to get to grips with. And so I'm just going to go through a measurement strategy. It's crucial to success. If you're not measuring, you don't know that what you're doing is an improvement. It may not be an improvement at all. And I plead with you to really focus on getting run charts together. And I can give you help in that regard and references, but also creating a measurement strategy around the different steps and stages in the work you're doing. I've taken here as an example neonatal hypothermia. Because if each individual collaborator doesn't understand the importance of measurement at every stage of the work, then the measurement won't happen. It won't be grounded in the research that we know needs to be what underpins our work. It won't be grounded in safe, timely, effective, efficient, equitable, and person-centered values. And it won't show us the tests that we are testing out, the fact that the processes that we've changed are now being delivered reliably and reliably under pressure. And lastly, those outcomes that are the things that we want to see shift won't be changing for some time. So we need to focus on what is telling us that those outcomes will change eventually, because if the processes that we are undertaking aren't any different from how they were before, the outcomes will not be shifting to the place we want them to be. So here we might look at, well, what happens in the pre-delivery environment that will protect the newborn infant from developing hypothermia. These are some ideas that I'm sure you already have considered. Are we using the monitoring processes properly? Are we doing the work differently? Let's test how differently we can do it, and then let's try and do it every time for every delivery this week. Then the outcomes will shift so that labor progress will be more accurate and the need for resus are less common. What about in and around the delivery itself, the environment of the delivery, reducing the risk of sepsis, having the right equipment, being prepared for the sometimes unexpected events that happen in a delivery, however well prepared we are. And that might be around things like incubator temperatures, sepsis screens, and the mitigation of sepsis risk. Changing our processes so that we always do it in a new way for every baby that is born. And then lastly, in the post-delivery environment, whether that's around maternal support, around support for feeding, around the warmth and the holistic environment, as well as education and coaching for the new mother. Again, always doing it in the new way, such that we see a shift in maternal confidence, feeding is secure, early discharge, and reduced neonatal mortality. So that if everybody can understand our strategy to measurement, then we are in a much better place to be certain that we are measuring at every step of the way. Measurement for improvement is very different from measuring for performance and measuring for research. And this valuable table is one that we encourage people to print off and have with them, because it helps us understand that we study each test. There will be a consistent bias in testing for improvement and measuring for improvement, but we understand that that will be the case. We're not running a research program, we're running a learning program. That we will be flexible and sequential, and we will collect the data in a time-ordered way so we can see the impact of what we're doing differently on the work that we're doing. We don't wait for a long period of time to look at the data. We want to look now and see what's happening now. We will test as our philosophy, not implement. And if a plan, do, study, act test seems large and complicated, it is. It needs to be small and achievable in the next delivery situation, in the next outpatient situation, on the next ward round, so that we can abandon the idea, we can adapt the idea, or we can adopt it and test it in tougher situations until we're clear it's as good as it needs to be and we can do the work in that way every single time we need to. So we developed this sequence of small plan, do, study, act cycles, building and testing a change, making it a routine part of our daily work, and then sustaining that over time. And it's only when that sustained improvement is in place that those complex outcomes that are dependent on lots of different things happening accurately and well for every patient, it's only after time that we'll see those outcomes shift. Sometimes we look for outcome shift too early in our learning journey. And then quality improvement skills. It's true you can go on a quality improvement course and then expect to put it into practice. But what I know from my work in collaboratives is it's important that people learn by doing. And it's important that we don't overwhelm people with quality improvement theory at the very beginning, and that we introduce it as it becomes useful and valuable, and that people are encouraged to use it there and then and put it into practice. You may have a quality improvement method that you want to keep as your main approach, and that might be the model for improvement, microsystems, A5, or lean. But I'm a little bit more of an advocate of choosing a method that works for the situation. Because in any clinical situation, you are likely to have some areas that will respond well to the lean and waste reduction approach, and others that need to be co-produced with patients where the microsystems approach might be better. We introduce fishbone diagrams, process mapping, driver diagrams right at the very beginning, as well as the plan, do, study, act approach. And we ask people to think about human factors and the idea that the people, the tasks, the environment, the tools, the technology in the organization are all key ingredients to a well-designed, well-delivered way of working. That way, people can put these approaches into practice at the very start, but of course, as they use them repeatedly, we leave a legacy of quality improvement skills behind that people will carry on using in their daily work, even when the collaborative is over. I definitely feel that sharing and promoting the value of quality improvement in action is key. And I've given you a link here to a conference that we started 8 years ago now here in the Southwest to give our trainees actually the opportunity to share their great work in a semi-formal environment using the ISQUA international guidelines wherever you can, so that people could share and promote the success of their own work and collaborate more widely. Here are 2 particular posters relevant to the collaborative focus that you've chosen. And as you can see, a very effective way through posters and presentations of bringing this work to the attention not just of other clinicians, but also of conferences, of journals, and so on. Things that are really important commendations of the effort that clinicians have put into practice. And then as I come to the end of my presentation, never be afraid to put your own driver diagram together. Here I've just created one for a team preparing to participate in a collaborative for the next 3 years, 5 years. Professionals and associated staff, infrastructure and local leadership, and a learning system are the primary drivers. Then the secondary drivers would be clear purpose, quality improvement skills, around infrastructure and leadership, having a measurement system, having leadership sponsors, people that we can go to when we have problems, that may need somebody more senior in the organization to help us with. And this culture of learning fast, failing fast, and adapting our solutions fast. And then, as we know, a learning system so that we're sharing all the time what ways we've developed for doing the work differently so that others might adapt them, or indeed perhaps just take them wholesale into their own working situation. Having that resource there to tap on at any time. So when we are thinking about the baseline audit that you will have almost certainly done to show where the gaps are in your care for neonates and maternity cases, is you will know that improvement methodology is a big ask and has at least 10 components to it, which I've put here. And this is what is so important about the improvement methodology in practice, that we do need to understand variation, the system where the work happens. Stakeholders need to be committed and involved in developing our purpose and to share it with us. We all may have ideas, some of them will be better than others. They all need testing. The right people on the team are key, and that we may need to work across several components in order to really maximize the experience and the improvement and the outcome and the benefits for everyone. And that evidencing the value of the work we do through measurement and through time-ordered data is a critical extra step that you need to take. Learning theory, whether that's by seeing, learning, reflecting, changing and redoing, or whether it's using Kirkpatrick's levels of learning in that we react to the learning, we learn to do it, it has impact, and then the results we see in our patient outcomes. These are sciences behind the way we should design the collaborative approach. And if we do so well, then we will see success. So a couple of quick reminders, because I think it is always important to understand where improvement science came from, because the insights that the originators of these ways of working had are just as profound, as important now as they were then. Every system is perfectly designed to get the results it gets. If you want different results, you have to change the system. Duran, very powerful observation that often it's a small part of our overall system that needs the change that will have the biggest impact on the system as a whole. And he truly understood the importance of measuring quality constantly as a dynamic process so that we could bring in improvement when we needed it and plan for quality at all times. Schuhart, he understood variation and he understood that data contains signal and noise. And if we wanted to understand what was going on, we needed to separate common cause variation from special cause variation. And that's about asking questions of the data we're looking at. How did this happen? What was going on? What can we learn? Could we do that more often if it was good variation? Or how can we prevent it happening ever again if it was bad variation? And then Deming, with his lens of profound knowledge, but also this profound observation that a bad system beats a good person every time. So our job as collaborators is to better our system at every point we can. So in your collaborations, you're moving from a good idea to a sound plan to real change for everyone. It will take time. It will take energy. It will take strength and resilience, but it will change lives, livelihoods, and communities. And for that reason, it's worth keeping going. It's worth talking and sharing and learning, and sometimes getting rid of things that you've done in a traditional way and changing them for a brand new way of working.